This is a young woman, relative middle-aged woman, and this is her CT. So you can
The
see
liver
that
looks fatty and she's got this big mass that's heterogeneous.
There's like cystic spaces in it.
Looks
Any
weird.
recent travel?
no, no, no.
And I would say it's enhancing, but not washing out. Like, sorry, arterial enhancing. Oh, and then there's a second lesion in the left lobe. Oh, several more lesions.
So there are many, many more lesions, and this mass is humongous.
So you like female fatty liver, always think about adenoma and adenomatosis, given there's multiple meds.
Let me just open. So then she had
Infection.
Okay, I'm gonna stop sharing just for a second, because sometimes it didn't puts back the names once I change.
Yes.
Okay. So this is like maybe a few weeks later, patient had an MR. You can see, pretty bad steatosis. You can see how all the little lesions kind of stand out on the outer phase. This is what when we talk about layers and we talk about lesional fat sparing, that's what we're talking about, right? So that just proves that these things are like true space occupying things, not just
The big one, does it have fat in it? I feel like it has areas that are dropping out.
It does not.
Oh, okay, okay.
It does not, but it does have, as Nelly, let me just do this. Let me do that. You can see that this is so it does have areas of kind of T2 hyperintense cystic spaces. The rest of the lesions are maybe slightly hyper on T2. They do have a little bit of diffusion restriction. The big one has diffusion restriction. So then you can see this is the pre, right? And because the liver is so fatty, it actually so you can see, let me just extend that up. So you can see that the T1, the in phase, right, which is technically, not technically, it's T1 without fat set, right? If you compare this, right, you can see that the lesion, if you focus on the background of the lesion without cystic space, is kind of isolated to the background liver. But on T1 with fat suppression, now the lesion stands out as brighter. That's because the liver is so fatty, it actually drops on the with frequency selective fat suppression. Anyway, and you can see the other lesions also stand out. Notice how here on the in phase, right, the lesions do not stand out, they're iso to the liver. But once you suppress the background parenchyma because it's so fat, you can see how many numerous.
Wow, there's a lot.
There's a lot, right? So anyway, so on arterial phase, you can see that most of them enhance, right? So they have arterial phase hyperenhancement. And then we have there. This is the portal venous phase. You can see that the cystic spaces in this main tomb lesion are kind of not enhancing, but the lesion itself remains enhancing greater than the parenchyma. So there's fading, but no washout, as Aarti said. You can see the rest of them as well. And this is hepatobiliary phase, right? You can see that the liver is kind of not as bright as we usually typically see in a young, healthy liver because it's so fatty. But you can see most of the lesions retain eovist. And the background of this lesion also retains eovist. So what you got to think?
Well, retaining eovist, usually think FNH, but I don't think that big thing is an FNH. So I'm thinking the one of the adenomas that retains eovist.
Right. So this is exactly what I wanted to show, that if you read the literature and it talks about, adenomas versus FNHs, and there's 5% of adenomas that retain eovist, and you can see that this big one does retain eovist, but hopefully nobody will call this adenoma just based on that, because it's so heterogeneous, has all these specific spaces. And then you can argue that the little ones, right, they do actually enhance fairly uniformly, right? You can see that. So if we didn't have the big ones, it would be hard to call these anything but FNHs. Anyway, so this was resected, and this is a beta-catenin background of beta-catenin mutated adenoma with foci of HCC.
I was wondering about that, like if the patient has like adenomatosis adenomatosis, and then one of them went wild and like turned into an HCC.
Right. So these patients are very difficult to manage because, you know, now you have the patient is now at risk for it, right? Because one of these things turn HCC, but aside from having from getting a liver transplant, you really can't get rid of the rest of them. So, you know, so this is management, kind of not easy management for these patients. So this particular patient gets close follow-up to see, you know, monitor these things. And okay, so I'm gonna stop sharing.
There's so many lesions. I mean, I guess we're just presuming that the rest are all adenomas and not HCCs, so that she can continue to be a transplant candidate, right?
Correct. So this is the difficult part. You kind of are stuck, assuming that they are all adenomas, and in patients who had explants in the setting of adenomatosis, somewhere close to 20%, they have heterogeneous subtypes of adenomas, so they don't always have to be the same type. So right, and then are some of those things not adenomas but FNHs? Possibly, we just can't tell. So it's hard, right? So for these patients, just have to follow them very closely and see, like, the patient could get the problem with the transplant, right? You don't know if any of them are actually HCC and if she's out of criteria, right? Like, she's actually out of criteria because her original adenoma is much bigger than 5 centimeters, and that has foci of HCC, so the entire thing is considered to be HCC. So she's out of transplant criteria. But even if, let's say, her dominant tumor was 4 centimeters, right, and the rest was these little lesions, you can argue that we can't tell if any of them are also HCC, so she could be out of transplant criteria. So these patients are difficult to manage. You just have to kind of follow and see if any of them are changing in size or changing in imaging characteristics. That then you have to assume that they're going bad as well. So as a companion case, I wanted to show, right? So this is a also large lesion, very similar to that other in terms of it's also fairly sizable, right? You can see that the liver in the background, there's no fat, right? The lesion is very similar on T1, so similar to the liver. You can see how, even though it's pretty large, it enhances relatively uniformly, with exception of these kind of lines inside. And here it is on T2, right? On T2, pretty much almost identical to the liver. On diffusion, nothing. Notice how it enhances, very similar to the liver parenchyma, right? And even though
FNH.
So this is FNH, right? So this is very different. So even though, right? So I don't think it's enough to say, FNHs retain contrast and adenomas do not. I mean, again, for like the specificity of like hepatobiliary phase hyperintensity is 95% specific for separating FNHs and adenomas. But there is some overlap. But I think for those lesions where there is overlap, you have to look at how they enhance and how, like, heterogeneity and how they appear. And that can also help distinguish between FNHs and adenomas. But sometimes as those little ones, the overlap does happen. So but that's pretty uncommon. Anyway, so that's what I wanted to show.
I have a question. In the earlier one, you had said something about 3% of adenomas retained, but like I thought, like lately there's some papers coming out that like maybe even up to 20% of.
So that's the problem. When they talk about EVIS retention, they don't talk about the pattern. So I have cases where, or I've seen papers where they show like this huge, ugly, beta-catenin adenoma, and there's like, it's 10 centimeters, and there's like one little patch that retains contrast, right? You wouldn't, right? So if you
right, like super heterogeneous, very different than like this situation.
If you scored it as, it retains contrast, right? It will go into those 20%, but that you do not want to. So I think that it's not just retention of contrast of EVIST, it's relatively uniform retention of contrast with exception of these septi, which FNHs have.
So actually, I just found this AJR paper from last year. Let's see, 2022. Hepatic adenoma subtypes on hepatobiliary phase, meta-analysis and systematic review from your colleague, Richard
Yeah.
Doe.
Yeah.
And he says the conclusion is that
Can you share the paper?
ranging from 11% to 59% of adenomas show ISO or hyperintensity on hepatobiliary phase.
Yeah.
The beta-catenin ones show up to 59%, and the
Whoa.
Right, but
unclassified ones show like 11%. So yeah,
this is
it's
what I'm
very,
showing. The first case I showed, it's a beta-catenin mutant, right?
yeah,
So it did retain contrast.
yeah.
You wouldn't,
You wouldn't call it an
you said I
FNH.
wouldn't call it FNH, right?
Yeah.
There's another meta-analysis, a little bit older one, that looked at, it didn't look at retention of contrast. It looked at hepatobiliary phase hypointensity. So if the lesion has areas of hepatobiliary phase hyperintensity, so that was 95% specific for separating FNHs and adenomas. So I think that, again, just saying, oh, it retains, you can't say, oh, if it retains EVIS, it's a flat out FNH. You can't say that. You have to look at the pattern. And I think the reason that this data, this meta-analysis, it doesn't, like, it just says, oh, it codes even those really heterogeneous, those adenomas which have some small areas of retention, very heterogeneous, you would not call them FNH, right? Does that make sense what I'm saying?
Yeah, totally.
So,
The one you showed, the FNH you showed, was like super classic, but I will say, like, some that I've seen that end up becoming
yes.
completely biopsy, the resection proven FNHs, like when they get large, they can get more heterogeneous than that.
Right.
So that's when it's like tricky. Like,
right, but
yeah.
but okay, but this is my approach. Like, when you call something FNH, you want to be damn sure you're calling something FNH. It's FNH. So you don't want, like, if it's not a typical FNH,
Totally
doesn't
agree.
behave like a typical FNH, then it absolutely deserves a biopsy or something. Like, because if you call in something FNH, you want to make sure that it's no doubt it's an FNH. So only classic ones. Anything that's not classic, I've biopsied FNHs, and whenever there's something not classic, I had one case that had washout. It was biopsy proven FNH, right? But you would not call FNH with these features. You would.
Yep. I've had washout. I've had microscopic fat in
Right.
them. Yep. Heterogeneity.
Yes, absolutely. Diffusion restriction. Right. So, but anything that doesn't fall into this typical appearance deserves to be either biopsied or closely followed, depending on how strongly you feel about it. Right. Because if you're going to say something is FNH, that means it doesn't need anything. Right. So you want to be pretty sure that, just like for hemangioma, right? You want to be sure that there's hemangioma if you can call something hemangioma.
Hey, awesome.
Yes, ready. This is a cystic liver lesion that puzzled us. There it is.
It's in like a good location for a ciliated foregut cyst, but
Great thought.
usually they're not multi-bubbly like that. Usually it's like one round lesion with cystic lesion with septations and stuff. And wait,
I don't think that's helpful, but here's your axial facet.
locally dilated bile ducts.
Oh, that's not really helpful either. I think the TSEs are better. Yeah.
And no central obstructing lesion.
No central obstructing lesions, yeah. And it's been around for a few years. So here's one from a year prior. There it is.
Does it connect to anything outside the liver? Feels almost like it extends outside.
Yeah, like these little things here.
Yeah,
Here,
but
here.
yeah, where is that inferior one connecting to?
Okay, well, can you pause? And I'm going to pull up the next case. This is another case.
Here it almost looks like a serous adenoma.
Let me give you the axials.
Okay, so I know when we talk about cystic lesions in the liver, we always talk about IPMB, MCN.
Mm-hmm. Yep.
I don't think it's an MCN. It looks too multilobulated. IPNB, you can get the cystic ectatic type versus the introductal dilation type. This doesn't look like the introductal dilation type. So I guess it could be a cyst ectatic IPNB. And is there such thing as a serous adenoma of the liver?
I don't know, but sounds good to me. Okay, can you pause? Okay, here's another case. So here's this one here. Let me just direct you. And this is a study from 2 years prior. Here. Same diagnosis.
Wait, this one looks totally different.
Yes.
Like a big cystic thing hanging off the liver with like a cyst and cyst appearance.
Yes. And let me give you the one that was I originally showed. That was several years later.
This one I
A
would have
year.
maybe thought about like a Echinococcus because it's got that like floating lily, like collapsed cyst within a cyst appearance.
Can you pause?
Yep.
And here's another case, same diagnosis.
This I would have thought Echinococcus versus MCN. But
So
maybe
all 4 cases.
Echinococcus.
Yes, yes. So all 4 cases that I shared with you are Echinococcus, pathologically proven Echinococcus cases.
Wow.
And I'm going to show you a radiographics paper. Sorry, can you pause for a sec? So this is a great
Wait,
paper.
it's Pedrosa. Is it Ivan? Oh, this is Ivan. And his dad.
Oh,
Look,
is
first
that
and
why?
last author. His dad is
Like,
actually a famous radiologist in Spain.
Oh, I didn't know that.
He probably wrote
Oh.
this when he was a resident in Spain.
Yes, it was not from Europe. I mean, it was not from US. It was from, yes, Martin Lagos, Madrid. Yes. Yeah.
So cool.
And yeah, 2000, 23 years ago. So this is all echinococcal disease. And let me just scroll down to some of the relevant imaging findings. So pathologists, they look at kind of the hooklets, and they can also look for these laminated appearance. And I'll show you some of the manifestations that we saw in MR. So the small cystic ones are kind of, it was hard, right? Because I was like, is it an MCN? Is it a like IPMB? I mean, when you start to see kind of the larger daughter cysts like this, you feel more confident. But the first 2 cases were really small cysts, cystic mass in the liver.
The one
But
that
you
you
can,
have right there, I think that's what they call like the ovary and the liver appearance. Like
oh, okay.
where you
Yeah.
see it almost looks like a torsed ovary with perforized follicles, but
Yeah.
you see
That's
those
what it
multiple
looks
follicles
like.
in it.
That is amazing. That is exactly what it looks like. I love it.
And then the last case, the last 2 cases had the laminated appearance of the collapsed membrane, parasitic membranes. So that became more obvious. And those are later findings. Yeah, they can calcify, but of course we're not going to see that on MR. But on MR can be a challenging diagnosis. So but they have a very similar appearance. Once you start to see them, they all look the same. Uh, the one, I mean, the
Cool.
cysts
So
were small
now if you
in my first 2
see,
cases.
no, go ahead.
No, that's fine. Yeah. So, anyways, like once you start to see a few of them, you realize they all look very similar, and they look different from like an MCN or IPNB.
So if you saw something now that looks like one of those first two, would you bring up Echinococcus? And then my second
Yeah.
question is that world map you showed is like, it's very, very much more endemic in other countries, like the Middle East and South America and places like that. So like,
Uh-huh.
was that a risk factor in these patients, or these were people from Arizona? Like, what is the...
The cases were from enterprise sites, so across, not just Arizona.
Okay, got it.
And
And they might be from, like, you don't know the demographics of the
correct,
patients.
yeah,
Got it.
but the first one didn't have, increased risk, or it wasn't helping. At least the demographics aspect of it, because that wasn't being thought about, right? It doesn't have a typical appearance of echinococcal, or at least it's an early, appearance of it.
Yeah, so a couple of extra things. One, you can test for peripheral eosinophilia if you bring it up. So that's one thing that they can do, like blood test. And then two, I've aspirated some of these, and there's always that like theoretical risk for anaphylaxis, so you just have to be careful. But you can do what they call like a pair procedure, where you aspirate it and then instill a scolidocetal agent and then reaspirate it. And that can help collapse some of them. But yeah, a lot of them do also go for resection.
I do have one more case that has that, what is it, the follicle and ovary appearance. Can I show that?
Yeah, sure.
Okay, can you pause?
You guys next week, I'm sorry.
Wow. So wait, you have another, this
So
is
this
another
is,
case.
yes, this is also pathologically proven case. And this is more of the MR imaging appearance of that follicle and the ovary appearance that you and Victoria discussed earlier from that radiographics paper.
Well, I call it ovary in the liver appearance.
Yes, ovary in the liver. Yeah, like the
Yeah.
palisating
Yeah.
follicle, that we can see, for example. Yeah.
So cool. Okay, so scrolling through, this is a youngish
Mass
male. Yes,
in
there's a
the
mass.
pancreatic head, and
Okay.
it's very homogeneous. I'm sorry, youngish, what was the gender?
Male.
Male. Okay.
Okay, there's the pancreas. You said in the pancreatic head. Pancreatic
Yeah.
head pushed
Or
here.
uncinate process or
And
something.
yeah, exactly. Like, okay, maybe is it arising from the uncinate process?
I thought I saw a claw sign, but maybe it's not. I don't know.
Well, it's always tricky.
Oh,
Like,
wait. Oh, you're right, actually, because I thought that uh, T2 hyperintensity was the pancreas, but it's not. The pancreas is a little bit hypo
exactly,
here.
right? So this is the pancreas.
Yeah, yeah.
And
Do you
then
have the coronal?
yeah, let me just point out that there's three components to this process. So there's
Yeah.
this guy, which is insinuating into the uncinate process, plus or minus claw sign. And then there's this guy over here. And then there's this big guy here. Okay. That's intimately
And
associated with the
it's
IVC,
yeah,
aortic.
like it's displacing the posterior structures.
Yep. Okay. You
Yeah.
want a coronal? Is that what you said?
Yeah.
Okay.
Just trying to figure out where it's coming from.
Sorry, get these measurements off. Pancreas.
Okay, I think
there.
yeah.
So there is that like intermediate thing that's affiliated with the pancreas, but the
Yeah.
dominant thing is kind of not. I'm gonna give you some more
It has an
information.
angular appearance on the left side. I don't know if that's anything.
Yeah, like a bulge here. Okay.
Yeah.
So gonna go to the not very T1 hyperintense, arterial. I'll point out, and I'm going to show you the subtractions. So the huge mass that was like T2 bright with a central scar basically does not enhance.
Yeah.
And the two other blobs on the side do enhance.
So something that like became kind of outgrew itself.
Exactly.
Like
So grew the
cystic.
blood supply, necrotic
Yeah.
here, but these guys are still active.
Yeah. So, I mean, in that location, I want to think about some kind of neurogenic tumor. I think the other thing I would consider is neuroendocrine tumor, like a
Okay.
cystic neuroendocrine tumor.
Okay. And I'll show you again, this big
Um,
blobby part is not enhancing, which is
yeah.
pretty impressive, given that it looks like this on T2, right? It looks like a solid
Yeah.
mass.
Yeah.
Pretty not enhancing. Okay. So you're thinking
Eh,
neurogenic tumor.
Yeah. And then, I mean, I'm still not sure if it's coming from the pancreas or not, but if it was pancreatic, I'd put like cystic spends can kind of look like that.
Okay.
But I think it's not pancreas. That's my feeling.
Okay, so and then let's focus on retroperitoneum. So we always we talk about neurogenic tumors. We can talk about paraganglioma. That's a
Yep.
good one. Lymphoma. Although I've never seen one so
Yeah,
devascular.
it's so discrete. Like it's so.
Yeah.
I mean, I guess you can have lymphomas that look like that, but they're more kind of they hug and surround stuff.
Yep. Okay. And now I'm going to give you the extra clue. It's a young male.
Oh, like seminoma, retroperitoneal,
Yeah. So
lymph
anytime we
node
see
metastasis.
big retroperitoneal masses in a young male, go look at them.
Oh my gosh.
And
Okay.
the answer was on the scan because we scanned all the way through the scrotum.
Oh yeah, look at that. Oh wow.
And here
Wait,
there
was that
is,
intentionally scanned through the scrotum?
we don't always scan through the scrotum, but I was very grateful that we did this time.
Wait, so it was accidentally scanned, then we happened to see it, or we knew the diagnosis?
It's a very good question, but like we don't always go through the scrotum. So
Okay.
we did not know the diagnosis at all.
Oh wow.
Yeah.
So you
No,
had
we did
like
not
you
tell them
clicked
like go
it.
all the way through, but they did. And there's this big 5 centimeter mass here in the right testicle, and they did an orchiectomy, and it was a seminoma. So
Wow.
seminoma. So I actually thought it was going to be a non-seminomatous germ cell tumor just because of the way that this retroperitoneal stuff looked. I was like, oh, maybe it's like different components, like yolk sac, embryonal, one burnt out and like outgrew its blood supply, blah, blah, blah. But still don't know really what's like why the retroperitoneal thing is so devascularized. But anyway, it's a classic seminoma and it had lymphovascular invasion. So just the teaching point is whenever you have a young male, always go check the scrotum, especially if you have a retroperitoneal process, because it can just look like a big mass and you don't even recognize that like, oh, these are metastatic lymph nodes.
Yeah. I'm sorry. And you thought it was non-seminomas because it was non-enhancing, like an embryonic, you said,
Yeah,
right?
I thought
Sorry,
it was
I was a little bit spacing
a
out earlier. Yeah.
yeah, like for example, we talk about burnt out germ cell
Yep.
tumors, which is
Yep.
like when
Yep.
they burn out in the scrotum, but then like
Yeah.
a mass, so I was like, maybe this is like the opposite where the retroperitoneal
Aggressive.
burnt out and outgrew its blood supply. And then we also remember we talk about like growing teratoma syndrome.
Yep. Yep. The
Parts of
cystic.
it can be like teratoma, and like most of these germ cell tumors are a combination of like yolk sac, embryonal, dermoid, mature teratoma, immature, like different things. So because there was different components, I was like, oh, this patient's pretty young and they have these different components. Maybe it's more of a germ cell thing, but turned out to be just a seminoma. And honestly, this part may just be a hematoma. Like maybe these metastatic nodes eroded some blood vessel and caused like a big hematoma here because it's so non-enhancing. So
But the T1 was not right, was it?
it was not, no.
Maybe it's an old hematoma.
Yeah. Yep.
But
Okay.
there's a little bit of peripheral T1, so
Yeah, very thin rind. Okay, hold on one second. Okay. So first of all, what do you?
the liver has like this geographic density.
Yeah, very sharp
Differential
line.
geographic, yeah.
So which side do you think is abnormal?
Right side,
Yes, why?
because it looks heterogeneous. And I'm just looking at the
Yeah, but
vessels.
say it wasn't heterogeneous. Say it was just like bright. Like which
Um,
side in general in the liver, when one's bright and one's dark, which side do you think is more abnormal?
when I don't, sorry. If one side is bright and the other one is not, then the bright side is abnormal. Is that what you're asking?
Yeah, which one is like which one are you more concerned about, the bright side or the dark side?
The right side, the right liver looks
Because it's
weird.
bright? Why? Why are you
It's
concerned?
lobulated. There's like this lobulated appearance, and
Forget
there's
about the
like,
lobulation. If
oh,
it looks completely normal and one side is bright and one side is dark, what are you more concerned about?
I don't know.
Okay, that's my that's my trick question. So you would think that you'd be concerned about the dark side, like, oh, is it ischemic? Is it infarcting? Whatever, right?
That
But
looks homogeneous and nice.
even if it's not homogeneous, the side you should be concerned about when you have a geographic abnormality here is the bright side. And that suggests that the hepatic artery is taking over and that there's something wrong with the portal vein on this side. So it's kind of
Yeah.
counterintuitive. Like every time we see like, oh, it's bright here and it's dark here, like people will tend to like think the dark side is, abnormal. But
Yeah.
anyway, so then now we go focus on the portal veins. Left
Yeah.
portal vein is fine, right
Like
portal vein.
clotted out. Yeah.
And then the heterogeneity, like you said, like
There's
these
a
are
mass there. There's like it looks like a tumor, like tumor in vein.
okay. That's one
I don't know.
possibility. Any
Uh,
differential for this stuff in the liver?
well, you get the perfusional change that you've showed us before. Do you have the
Right.
corona
So
by any chance?
we've got a portal vein thrombus, and then
Yeah.
we've got a geographic perfusional change, and then we have scattered, ill-defined hypodensities in the right lobe.
Yeah. Like, I don't know. To me, it looks like infiltrative tumor.
Okay. I will tell you it's not infiltrative tumor. So anything else
Okay.
differential?
What else?
So I'm just going to show you the rest of the abdomen.
Like an infection
Exactly.
right there.
So,
There's a little diverticulitis or some kind of
exactly. So there was a
diverticular
little
outpouching
contained perforation, a little contained
abscesses.
collection from a diverticulitis. And then this was actually basically a septic pyelephlebitis with
Yeah.
micro abscesses in the liver. So whenever you have like a thrombus, you think could it be tumor thrombus or bland thrombus? And on a CT, you can't really tell. I'm going to show you an MRI where it looks like a bland thrombus and these look like micro abscesses. And then if you think there's liver abscess or there's septic pyelephlebitis, which is infected thrombus of the portal vein, you go look for a GI source. So appendicitis, diverticulitis, etc. 50% of the time we never find the source because it already resolved. But in this particular situation, we have a little, perforated diverticulitis here. So I'm going to show you the MRI now, just to round out our imaging of this. And so first of all, and actually, unfortunately, we didn't have a post contrast because the patient couldn't tolerate it, but we do have a few sequences that are interesting. So, again,
Great mimicker.
yeah, exactly. So we've got this ill-defined stuff that's like phlegmon, right? All like, look, these look like micro abscesses with edema,
Yeah.
and then up here as well. And then, we didn't have a post contrast, but there are things you can, like on the flow void, like, oh yeah, this looks like thrombus here in the right portal vein. It doesn't look evil gray like a tumor
Very
thrombus.
bright. It's
It's
very
very
like,
bright, right?
do
So
you have,
it's
I
like
bet
basically
diffusion could
pus.
help,
Let me see if I have
or
diffusion.
maybe not. Wait, so why did you move?
Oh, you know what? By the way, diffusion does not help because both
Oh,
bland thrombus and tumor thrombus will have restricted diffusion.
oh, I see.
So,
What led to the MR?
I don't know actually. Let me see. Maybe the CT was
Like
wishy-washy.
non-diagnostic, yeah, or not, yeah. I could see that because I can.
Yeah, they basically said indeterminate lesions in the liver could be abscess versus focal lesions. Recommend MR.
Yeah.
And then also there was some like other renal and adrenal stuff going on. So anyway, okay. Scrolling through.
Something going on in the kidneys.
Okay.
There's
I'm
like
just gonna
this.
stop like here.
Both kidneys are edematous. They're kind of and there's this hyperdensity along kind of the course of the collecting system. Like
Yeah,
maybe the
so there's
patient
some
got
excreting contrast, I will say, from
excreted.
like a prior CT.
Yeah.
But they look edematous, right? We don't see any
Yeah,
of the
yeah.
fat.
Can we check the vessels? Like look for clots
This
somewhere.
is a non-contrast. That's all
But
we have.
sometimes you can get dense, like you can get expansion of the vessels.
Right. So exactly, like for example, renal vein thrombosis bilaterally, that would be a little weird to have bilateral, but like if the IVC was thrombosed, that could lead to this kind of super edematous appearance where you don't see any of the fat, right?
And the aorta looks funny.
Nice,
There's
nice,
like
nice.
a lot of
Okay, wait,
stranding
just
around the
one more
aorta.
thing about the kidney. Like this is also kind of like a faceless kidney appearance, right? Like it's just that's what we call faceless
Yeah,
kidney when
that
like
makes
it's
sense.
lost
Yeah,
its fat.
right.
I want to point out one thing though. Like, do you see this little? You can almost see that there's
The
like a
rind.
rind, right?
Yeah.
Okay. And then you said the aorta looks funny.
Yeah, like they're both dead kidneys or something.
Okay, they could be dead kidneys. And then the aorta, what do you think about the aorta?
There's stranding. There's some kind of inflammatory
Stranding.
process happening
Okay. Can you connect
around
the
the
two?
aorta. Yeah, like you can get aortitis, and then clot up the renal arteries bilaterally.
Okay. Anything else?
Um, what else? You can dissect it. I don't know. There's some kind of vascular process, systemic vascular process. Is
Okay.
my thought.
Also a possibility. Okay. Now I'm going to show you an MR a few months later. And it looked like this.
Oh, whoa. Wait. So is there retroperitoneal fibrosis? I mean, there's like, I don't know. I mean, there's this thickened rind around T2 dark. And when I see that, I think about and uh, NPH, um,
NPH,
like the
PNH?
or PNH, sorry, PNH. But then like, how do we tie that with the vascular findings?
Exactly. Okay.
Um,
So there's
I
something
mean,
perinephric. There's also something around the adrenal glands.
like,
And then there's a similar T2 dark thing around the aorta here. And show you a post contrast.
yeah, interesting. I mean,
This doesn't really help. It's a lot of, but anyway, I will just cut to the chase. The patient also had orbital swelling. And so this patient has known multi-system IgG4 disease,
oh my gosh.
and they have been treated with steroids and then actually multiple rounds of rituximab, I think. And this is basically chronic fibrotic retroperitoneal fibrosis, perinephric, periadrenal, and periaortic.
Oh,
Chronic
wow.
IgG4 disease. Yeah.
Wait, I'm sorry. Orbital swelling is like a feature of IgG4?
Yeah. So it likes
Oh.
to go to like parotids, orbital glands, lacrimal
Oh,
glands, salivary glands. And then they also then had like this new pain and they were thinking there might be giant cell arteritis. But anyway, they have known IgG4 disease and they've been on like years of treatment with both steroids and rituximab.
wow.
Yeah.
What
So
an
in
awesome
the acute
case.
phase, you can get perinephric. So renal IgG4 in the kidneys can be like focal deposits of IgG4 with like you get like multiple hypoenhancing masses, but it can also just be perinephric. And in the more acute phase, it'll be more more inflammatory, right? But here we can see that it's just that super T2 dark without a lot of inflammation. The fat around it is really pretty good. So this is just like treated / fibrotic IgG4. And we get in pancreas, we get a rind around the pancreas, like same thing,
Yeah.
again, that sort of T2 dark rind. So yeah, just treated.
Was like the hepatobiliary or the pancreas? I mean, I don't see any
Nope.
disease there. It
So
was
good.
just isolated renal and adrenal and
And
aortic.
aortic, yeah, I am.
Oh, wow.
And nope, we've got some IPMNs here, but otherwise
Yeah.
no sausage pancreas, no rind around the pancreas, no beating of
Yeah.
the pancreatic duct, and then no PSC-like beating of the biliary tree.
Oh,
Which I like looking at the post contrast because I sometimes see it better. This one is motion degraded, but yeah, we didn't see the beating. So yeah, which is cool.
that's pretty amazing. Great case.
Yeah. Okay, so there's like a weird renal lesion. Kind of ignore that for now. And then there's this thing on this side.
Yeah.
Creepy. Just
Where
wait.
is it? Is it in the
Big
diaphragm,
contrast.
like posterior pleural space, or is it
Very,
in
yeah, it could
the,
be very low in the posterior pleural space. Here's the
yeah,
arterial phase.
rim enhancing,
Venous.
gallbladder? Where's the gallbladder?
Gallbladder
Gallbladder's
is
gone.
gone.
Gone. Okay. Sometimes there's like dropped gallstones that can develop into an inflammatory process in that space.
Exactly. So this was drop gallstones and with a chronic abscess. And so this is classic location, but they like to drop into this like dependent space. And just as for comparison, I'm going to show you a prior CT. And this was, let's see, a few years earlier. And you can see some tiny hyperdense foci here, right? And that those
Yeah.
are the little dropped gallstones that eventually caused a chronic abscess.
Wow.
So yeah, you got it. Great. It's an Aunt Mini. And so if you see an abscess looking thing in this space, always think about dropped gallstones. Go look to see is the gallbladder there, blah, blah, blah.
Old is gold.
Yeah. And then sometimes the CT can show you more like the calcified part of them. And the MR more just shows like a sort of abscess in that area. So
Great case.
okay, see you next time.